Host you. Doctor, so we are live now. We can start with our webinar. So welcome all the participants and the doctors on the webinar on master classes in fetal surveillance. A big thank you to all the doctors for taking the time to join us today. Let me first introduce our esteemed doctors. Today we have Dr. Arulkumaran, who is a renowned professor emeritus at St. John University of London, with current roles at University of Nicosia and Imperial College London. His contributions to medicine have earned him a Knight Bachelor by the late Queen in June 2009. Dr. Arulkumaran will be discussing normal and abnormal second stage CTGs in today's webinar. Next, we have Dr. Sujoy Mitra, HOD of Obstetrics and Gynecology at Command Hospital Air Force, Bangalore. He's an expert in high-risk pregnancies, minimal access surgery, urogynecology, and gynecologic oncology. Dr. Sujoy will be discussing antenatal fetal surveillance. And we have Dr. Anju here. She's a gold medalist and a DNB certified gynecologist. She serves as the director of Jain Hospital, Varanasi. With expertise in fetal medicine, high-risk pregnancy, and hysteroscopy, she has made significant contributions to maternal healthcare. She will be discussing about the interesting cases on CTG interpretations. So today I will like to ask Dr. Arulkumaran to start with the webinar, and then he can take it forward.
Thank you very much for the kind introduction, and
thank you.
Delighted to join the rest of the group. So let me start with my presentation. I hope you are able to see the presentation.
Yes, sir, it's visible.
Okay, thank you. So today I'm going to discuss about normal and abnormal second stage CTGs. The first stage CTGs are slightly different from the second stage CTGs. So I just want to look at the normal, what is normal in the second stage and what is abnormal in the second stage CTG. So this is the NICE guidelines which we follow in the United Kingdom in December 2022. They defined the categorization of cardiotocography in all stages of labor. They said include CTG categorizations as part of the full assessment of the condition of the woman and baby. Be aware categorization is a tool which quickly communicates the current state of CTG and should be used together with the antenatal and intrapartum risk factors to assess changes over time. So this is crucial. We must know whether the baby has growth restriction, whether there's thick meconium, there's bleeding, there's preterm, postterm. Those risk factors will influence how quickly the baby will get acidotic with the given CTG. Number two, categorization of CTG traces as follows based on whether each of the four features. So we have to look at the contractions, baseline rate, baseline variability, decelerations, and they have been scored as white, amber, and red. White means there's nothing to worry. Amber is there's some concern, so we have to watch the trace carefully or do some action if there is severe high risk factors. Or red, that means this needs some action. We have to really decide whether to deliver or whether to proceed or whether to give tocolysis and so forth. So that is the definition, no amber features, and suspicious is one feature which is amber. One feature out of the baseline rate or variability or decelerations or too many contractions, then it becomes amber. Pathological is one feature red. That means it is quite abnormal in terms of the baseline or the decelerations. And otherwise, two or more features are amber. That means the baseline rate is high and too many contractions or late decelerations, but the variability is intact. So we'll go through that in detail, but take into account any change in the categorization of the CTG alongside other antenatal intrapartum risk factors for hypoxia and discuss the changes in its implications with the woman and take account of her preference when deciding how to proceed. So we are expected to talk to the mother and see this is the situation, and maybe I'm still in doubt or whether I'm convinced that the baby should be delivered. So we have to have a frank discussion and then take her wish also into consideration. Now, in the second stage, it has a separate section and it says take into account the interpretation of the CTG trace in the second stage of labor is more challenging than the first stage of labor. So that's why I've taken this topic. Why is it more challenging? And we must have a lower threshold of seeking second opinion or assistance because the rapidity of acidosis and hypoxia is much higher in the second stage because the contractions are more frequent and the head being in the pelvis presses on the uterine vessels and reduces the blood flow. And therefore, the baby tends to get acidotic. And obviously, there's a quick win because we can deliver most of them by assisted vaginal delivery using a vacuum or a forceps. So that is the reason that in the second stage is more challenging than in the first stage, have a lower threshold, and if you need it, ask for a second opinion. Now, number two there is ensure the fetal heart rate is differentiated from the maternal heart rate at least once every 5 minutes, because the baby's heart rate is bradycardic, and if you use an ultrasound transducer, it might give the maternal heart rate, which we might think it is a fetal, but we are recording the maternal. That's by ultrasound. But if you listen with a stethoscope or use a ECG clip, then you won't make that mistake. Consider monitoring the baby with a fetal scalp electrode if there's concern about confusing heart rates, but if this cannot be achieved, expedite birth. It goes on to say, if the fetal heart rate accelerations are recorded, be aware that these are most likely to be maternal pulse, and steps should be taken whether the maternal or fetal heart rate is being detected. Because the characteristics of the second stage fetal heart rate is for it to decelerate because of the head compression with the head going down, whereas the maternal heart rate is because the uterine contraction squeezes the blood out of the uterus into the systemic circulation. There's a rise in the baseline rate in coinciding with the contractions in the second stage. So if you see second stage accelerations coinciding with the contractions, then probably we are looking at maternal heart rate. If fetal heart rate decelerations are recorded, look for other signs of hypoxia, for example, rise in the baseline rate and reduction in the variability. So there are features which tells whether condition of the baby is deteriorating and we should immediately deliver. And that depends on whether there's a rise in the baseline rate, fall in the baseline rate, prolonged deceleration, reduction in variability, and so forth. So these are the features we are going to look at in a short time. Now, take into account the onset of hypoxia is both more common and more rapid in the active second stage of labor. As I mentioned, there could be occult cord compression or pressure of the head on the uterine vessels. And in addition, if there is reduced retroplacental pool of blood, then the baby compromised much earlier. Take an increase in the baseline heart rate or more from start of the labor or since last review 1 hour ago as red feature in active second stage. So that if there's a rise in the baseline rate, it's not a good thing. The baby need to be delivered, especially with the rise, there's absent variability. Now, if the CTG there's concerns in the second stage, obtain an obstetric review. This refers to the midwives to call the doctor and consider discouraging pushing and stopping oxytocin infusion to allow baby to recover unless birth is imminent. Now, this is an important concept because when the baby has decelerating, the number of circulation through the baby's placenta is much reduced because of the bradycardia or the deceleration. So if you ask her to keep on pushing one after the other and decelerate soon after, it's like pushing a baby underwater very frequently and the baby gets acidotic. If you ask her not to push and the heart rate remains at the baseline, then the baby has time to ventilate it, like keeping the baby on the surface of the water instead of pushing it down all the time. Agree and document a clear plan with limits for the next review. So these are quite important. For a short explanation why the committee made the recommendation, then there is a separate section on the guidelines for us to read. So let us look at the actual traces. Now, early deceleration with the onset and offset of contraction, usually less than 40 beats, are called early decelerations, and they will have normal variability. So if you look at this trace here, the variability is normal. And if you draw a line at the beginning of the contraction and the end of the contraction, the deceleration will fall between those two lines. So that is early decelerations compatible with head compression. So normal baseline rate, normal baseline variability, and the contraction is a mirror image of the deceleration and falls between the two lines of the onset and offset of the contractions. Now, if you look at this, it looks similar, but if you draw the line carefully at the beginning and the end of the contraction, the deceleration falls outside the second line at the end of the contraction. The deceleration is still outside. So that means these are late decelerations, but the baby is not in trouble because the baseline variability is maintained. But it might run into trouble if the baby is growth restricted, meconium, or if it is going to take a long time. So this is the subtle distinction between the early and late decelerations. Traces look alike, as you could see, but by drawing two lines, one at the beginning and one at the end of the contraction, you should be able to know which one is to be of some concern. Now, of course, if it is the same trace, where when you draw the line, it'll fall outside the second line, those are late decelerations. But if the variability is absent, then that baby is already hypoxic. So the key to hypoxia is baseline variability because that represents the function of the autonomic nervous system. The sympathetic pushing the baseline up and parasympathetic pushing it down. So that is indicative. And with such a trace, if there is thick meconium or absent fetal movements or bleeding, then it needs immediate intervention. Now, what is normal other than early decelerations is the decelerations which are variable due to the pressure on the orbit, like an occipital posterior position. There, what happens is the baseline rate is steady. As you could see at around 155, the variability is maintained, but the deceleration drops and remains for 42 seconds to 1 minute at the lowermost point because of the pressure on the orbital region. So if it is due to cord compression, it'll pick up very quickly, like a V, whereas this one is not. So this is remaining, and that is occipital posterior, occipital transverse position. So it takes a longer time for the baby to come out. And this is well documented in the literature because if you get such decelerations in the first stage of labor, you have to think whether it's brow or face presentation. Of course, this baby will come to no harm if the baseline rate remains the same and the variability is present. And most importantly, the interdeceleration interval between the two deceleration is longer than the deceleration duration. So it means you're pushing the baby down, but you're keeping the baby on the surface of the water for a longer time for it to oxygenate itself. So that is due to occipital posterior, and there are a number of papers which has described this, and it says in the number of fetuses, there was 4.5% born in the occipital posterior, and it says there is no difference in terms of Apgar scores and outcome, but it shows the typical variable deceleration with the deceleration lasting for a shorter time. Now, this is due to cord compression because this is not whether it's coming, not coming, and staying for a longer time, but it reflects again back to its baseline. But if you draw the two lines, and the deceleration will fall outside that line. So variable deceleration due to cord compression are related due to chemoreceptor response and reduced coronary reserve. And if it increases, then the decelerations will come more frequently and last for a longer time. So like a variable followed by a late. So for a longer time, the baby is underwater. So that means it's becoming less and less time at the baseline, and this baby will get compromised sooner. So more V-shaped if there's a cord compression deceleration, compared to a head compression deceleration. And you have to observe whether the duration and the depth of the deceleration is increasing. That's a bad sign if both increases. In addition, the interdeceleration interval gets short, getting shorter and shorter, and especially the baseline rate is going up. Then you ask her to lie on the side, ask her not to push. So you can keep for 3, 4, 5 minutes at the right baseline so the baby can oxygenate. Then you can ask her to push. In other words, every 3 to 4 contractions, no pushing, and then you can push once so that the baby won't get hypoxia and acidosis. Now, this is explained in the graph here. Usually, the decelerations, which they are variable due to cord compression, the deceleration falls within these two lines, and the interdeceleration interval is longer. As hypoxia pursues, the deceleration becomes deeper and wider, and the second line cuts the deceleration, and which indicates the interdeceleration interval is going to get shorter and shorter and shorter. Now, at the same time, we can observe the baseline rate going up. That is due to catecholamine surge, and finally, the variability getting absent. So in other words, there's a progressive change in terms of the duration and the depth of the deceleration. And in addition, the interdeceleration interval is getting shorter, which is not expressed in the CTG guidelines because it's too laborious to put it in. But we had to just imagine dipping a baby underwater. If you take the baby and leave it for 5 minutes and then dip it again, that baby is going to survive. But if you keep on dipping and the interdeceleration interval becomes shorter, there's a chance of hypoxia, and it'll be reflected by rise in the baseline rate and reduction in baseline variability. So having that as a background, I'm going to show you 10 features of second stage CTGs which can give rise to problems and how quickly these babies need to be delivered. So one is prolonged decelerations where the heart rate drops to below 80 and remains below 80. This is usually due to cord compression, abruption, scar dehiscence, and it can be physiological due to too many contractions, and you have to decide which is which. The second is, so here the baby has to be delivered within 12, 15 minutes. Subacute is deceleration lasts for a longer time rather than at the baseline rate. So here 30 to 45 minutes, the baby should be out. And number 3, declining baseline rate with subsequent deceleration. So the heart rate, every time it comes down and down and down, so suddenly it'll become bradycardic. Rise in baseline rate with subsequent deceleration. So the baby's heart rate goes up and up, and it might go to a point and suddenly it'll become bradycardic. So you have to observe that. Doubling on the fetal heart rate. The fetal heart rate, if it is bradycardic, less than 80, if you monitor the baby with ultrasound, it might give double the heart rate because of a phenomenon called electronic window. The sixth point to note is coinciding fetal heart rate with maternal heart rate. So you're recording, there are two recording going on, and you think one is fetal, one is maternal, but both can be fetal because the method of recording the fetal and maternal is slightly different. And 7, recording maternal heart rate instead of fetal heart rate. This is what I explained earlier and mentioned in the NICE guidelines, that if accelerations coincide with the contractions in the second stage, then those are likely to be maternal. Number 8 can be a sudden switchover from fetal to maternal heart rate. A decelerative trace suddenly become accelerative. That means the baby has a bradycardia and the machine is picking up the maternal heart rate. Poor recording of the fetal heart rate is associated with severe acidosis, so you have to, if there's no possibility with the ultrasound transducer or electrode to get the heart rate, you have to auscultate because that'll give you a better idea. And finally, in the second stage, there's always possibility of occult cord compression, or you might give her epidural when she's in the second stage and ask her to bend, and the head will go and jam into the pelvis and reduce the oxygenation of the fetus, and that gives rise to saltatory pattern, and that has to be recognized. And we're going to see all these heart rate patterns as we go along. So number 1 I mentioned was prolonged deceleration, that is the heart rate drops below 80. This can be due to prolapse of the cord, loops of nuchal cord around the neck 3-4 times, abruption, scar rupture, or unknown. Sometimes we don't know. Here, the baby has to be delivered within 12, 15 minutes. And this has been shown in a study which we published in 1985, December, in the American Journal, saying the pH will drop by 0.01 every minute, and therefore the urgency, and don't wait for more than 10 minutes. And the same observation was made 25 years later by Tiva Leung and his group. And they also mentioned the pH decreased, as you could see in the abstract here, by 0.011 per minute, which is similar to what we discussed. So acute bradycardia, the answer is here to deliver within a very short time. Now, subacute pattern can happen in the second stage, mainly due to cord compression. It is having head compression deceleration, and as the head descends down, maybe 3-4 loops of cord around the neck or something, it has prolonged deceleration. That means the duration of deceleration is much greater than the duration at the baseline. So the baby is being pushed down underwater, comes to the surface for 30 seconds, pushed down again. So the number of circulations are compromised. And here the pH will drop by 0.01 every 2 minutes, and the baseline rate becomes saltatory baseline variability due to hypoxia. And this is 10 minutes interval. I'm going to show you the babies. You're dipping the baby for a longer time, taking the baby to the surface. If you get such patterns in the second stage, it needs delivery because the baby is going to get compromised by 30 minutes or 40 minutes, and then suddenly it'll be bradycardic. So this 40 minutes, pH would have dropped by 20 points, and 1 hour dropped by 30 points. And then it becomes bradycardic and delivered at 112, which means the pH would have dropped by 10 points in that 10 minutes. So 30 points dropped. So if the pH is 6.79 or 6.8 at the beginning of the trace, probably the pH was 7.10. So if it would have delivered at 20 minutes, then it would have been 6.9 to 7, and the baby would have done well. So this particular baby, because of prolonged partial hypoxia, it has bilateral cortical atrophy and spastic quadriplegia, and the terminal bradycardia gives us thalamic hypothalamic injury, needing tracheostomy and gastrostomy and so on and so forth. So we have to observe these traces very carefully. The third pattern to observe is if the baseline variability is absent with decelerations, then the heart rate is going to be going down. The top of the baseline is going down and down and down, and it's called stepped ladder pattern to death. It'll go gradually down and down. Now, if you would really, as soon as it starts coming down, intervene and deliver, then you can resuscitate that baby. But if you wait for the heart rate to go from a rate of 160 to a rate of 120 and 100, drop of nearly 60 beats at the top of the baseline, then the baby will find it difficult to be resuscitated or have cerebral palsy or HIE at delivery. So falling baseline is not a good one. And finally, the same trace, as you could see, gradually coming down and gradually walking its way to death. This was forceps done, but it was a stillbirth and ends up in a terminal bradycardia. Now, progressive rise in the heart rate is also not a good thing, and shouldn't wait for a long time. So here the baby has been monitored by an ECG and a heart rate, and it shows deceleration, and baseline is 140. And although there are deceleration, there are intervals where it is longer at the baseline and the variability is maintained. As we go along, the heart rate from 140 has gone to 160 now, and there's some reduction in the baseline variability, and the interdeceleration interval tend to get a bit shorter. They managed to see her, and at this point here, cervix was fully dilated. Now the 140 heart rate has gone to 170, but the variability is maintained. But suddenly, as she approaches the second stage, the duration of the deceleration is getting longer, and the interdeceleration interval shorter, and the baseline has gone up due to catecholamic surge from 140 to 180, 140 at the beginning of labor. So you have to do something, and she advanced very well, and within a short time, she delivered with UPCAS 9 and 10 with a pH of 7.0. Suppose if she was not delivered spontaneously, then we should have assisted as the heart rate went up by 20 beats or so. Because otherwise, there will be a sudden bradycardia where it goes up and then it becomes bradycardic, and you will be in a rush to deliver and run into trouble. The fifth pattern is two heart rate with doubling of the fetal heart rate. So here, the heart rate drops, but there's another heart rate coming, which is exactly double, 75 to 150. And this is because of hypersystole, and she's on oxytocin, and the uterus is more sensitive to oxytocin as the labor advances. So the hyperstimulation is partly due to oxytocin, partly because of Ferguson reflex. In second stage, when the head is getting compressed, that's compressing the upper vagina and the cervix, there's a reflex release of oxytocin called Ferguson reflex. That makes the contraction too frequent, and as a result, the baby has bradycardia. And if it is monitored by ultrasound, sometimes it gives double the heart rate. So the doctor thought this was maternal, this was fetal, but both are fetal. And that's at 75, that's at 150. So one has to recognize. So here the oxytocin need to be stopped, asked her not to push, and could have managed. But they waited without thinking one is fetal, one is maternal, and therefore the UPCAS was low and the pH was 6.8. Now the sixth confusion is maternal heart rate being recorded by two devices. So here the baby is dead, but you can see overlapping recording, where some monitors use the infrared from the maternal tocotransducer to give the recording, and the ultrasound to pick up the heart rate, but the ultrasound sometimes picks the maternal vessels. So there are two coinciding heart rate patterns, as you could see. That means probably the baby is dead or severely bradycardic, and we should have taken action. Now, I mentioned about the pattern described on the CTG NICE guidelines, where there are accelerations coinciding with the contraction, which means we are recording the mother. So here is 32 years, 41 weeks, 5 days. She had some pyrexia. She was established in labor. This is a very poor recording technically. The fetal heart rate is about 155, no contraction recording. Here they say vaginal examination fully dilated at 3:40 in the morning, and they readjusted the transducer at 3:40, 3:50, and at 4:10, the baseline, which was 150, has become 120, a different type of recording, and the heart rate is accelerating with the contraction. If you draw a line at the beginning and the end of the contraction, these are accelerations. These are maternal heart rate, because the uterus squeezes the blood into the maternal circulation. So they were thinking they were recording the fetal, but they were recording the maternal heart rate. So if you find accelerations coinciding with the maternal, the contractions, then you have to think they're maternal unless proven otherwise. And the UPGAS scores are 0 at birth, 0 at 1 minute. And they were thinking unexpected outcome, but they were recording the maternal heart rate. This has been shown by experiments where people have put a precordial ECG lead on the maternal heart rate, and when she's pushing, the maternal heart rate goes coinciding with the contractions. And once the baby is delivered, it gives a straight line. And many of us, we know, we deliver a baby and baby is out, but the monitor is giving a tock, tock, tock sign that is recording the maternal heart rate. Now, the other pattern to remember or to recognize is sudden change. So this is decelerative, and this is due to head compression. And she's pushing, as you can see from the pushing spikes or the contractions. And in this moment of time, just a little behind the vertical axis, suddenly the heart rate becomes accelerative, and it is coinciding with the contraction. So at this point, the monitor has switched from recording the fetus to the mother, because probably the fetus has a bradycardia, and conveniently it picks up a maternal vessel. So this needs to be noted. There's a sudden change. Now, poor quality of recording is the other problem in the second stage. The field heart rate is difficult to interpret when there is persistent signal loss. The situation should be corrected by adjusting the transducer or obtaining via a scalp electrode. If needed, we change the connections of the machine. If these actions do not rectify the problem, you have to get on with intermittent auscultation. And if possible, it is still difficult to auscultate. Think whether it is possible to deliver by assisted vaginal delivery. So this is an example, failure to obtain good quality trace. Can see the prolonged decelerations, but it is hidden because everybody is looking at it saying there's the baby's heart rate, but nobody is bothered to see these decelerations are going to cause problems to the baby. This goes on, and probably she's being hyperstimulated. We don't know because the recording of the contractions are not there. And it has been shown in the literature that you can use different systems to classify second stage CTGs. They have a moderate accuracy in detecting acidemic fetus, but the occurrence of unclassifiable findings seems significantly more common among the acidemic fetuses. So if the heart rate is unable to record properly, then there's a greater chance the baby is going to be acidotic. And finally, saltatory pattern, where the baseline variability is more than 25 beats. If you draw a line at the top most and less than 25 beats. And this is really due to acute hypoxia, which is happening. And usually in this late first stage, second stage, if you record without giving an epidural, and if it doesn't resolve in 20, 25 minutes, when you put on the lateral side and give her some oxygen, then that means it's going to deteriorate here. And here it was deteriorating. And they managed to try and deliver, but it was fully dilated with an OP higher up. So they did a C-section. The baby was born asphyxiated. And it was a neonatal death because this is bradycardic. So saltatory patterns, which doesn't resolve within 15, 20, 25 minutes, you have to probably take some action. Now, what action can you take? Well, you can take sympathomimetic drugs. So this is papers. These are papers published by us in the 1980s, and which shows that if you can abolish the contractions, then you can recover the fetal heart rate. And it's significantly, fetal heart rate and acidosis significantly improved with acidosis after autocolysis. And suppression of ischemic effect or contraction on the placental circulation is relieved. Mild side effects. The mother will have a little bit tachycardia and she will get flushed. But lack of maternal complications is a good reassuring thing. So the NICE guidelines describes to give terbutaline 0.25 milligrams subcutaneously. You can give it intravenously, but you have to give it slowly. Otherwise, there'll be severe tachycardia and remarkable perinatal outcome. Now, the terbutaline has to be given as subcutaneous or slow intravenous. If you give it as a nebulizer, like puffs in the respiratory system, it doesn't cause any reduction in uterine activity. And this was shown by a group in 1991. Asha Kurup, who was my lecturer, published this paper, which shows that if you use 4 puffs or 8 puffs, it doesn't reduce the uterine activity. But if you give intravenous, then there's a drop in uterine activity within 15 minutes by 75%, and it takes time. So this will buy us time for the contractions to stop and the baby's heart rate to recover. And this is a typical example of a decelerative pattern. And here, if you don't give any tocolytic, even if you decide to do a section or a forceps, give the medication because these contractions are going to make the baby acidotic. And by the time you decide, okay, I'm going to do a section or I'm going to do a forceps, and if you don't do anything, by the time the baby is born, the baby will be acidotic at this time. Whereas if you give the tocolysis here, you abolish all the contractions and the decelerations and the bradycardia, the baby's heart rate would have recovered and will be born in a good condition. So I would like to acknowledge Dr. Leonie Penna, who was my senior lecturer, for giving me this praise. So in summary, I have gone through normal and abnormal second stage CTGs and what to do. And the patterns are prolonged deceleration, acute hypoxia, subacute deceleration lasts longer compared to the rate at the baseline, like dipping the baby into water for a longer time and taking the baby for a shorter time, declining baseline rate with subsequent deceleration, rising baseline rate with subsequent deceleration, doubling of the fetal heart rate, coinciding fetal heart rate and maternal heart rate raise, recording maternal heart rate, which are accelerating with the contractions, switch over from fetal to maternal, poor recording of the fetal heart rate, and saltatory pattern. So consider stopping oxytocin, assisted vaginal delivery, not to push, ask her not to push. Don't be in a panic. And tocolytics if you decide to deliver vaginally, instrumentally, or C-section to give some intrauterine resuscitation. And rarely you might have to end up in a cesarean section. So there's more compromise in the second stage, and it's much quicker, and it's useful to know when and how to intervene. Thank you very much for your kind listening.
Thank you so much, Dr. Arul. I would like to Dr. Sujoy to take forward the presentation.
Is it okay?
Yeah.
Can you hear me?
Yes,
Yes, sir.
yes, you can
Okay.
start.
Good afternoon, everyone. I'm Dr. Sujoy, and I am currently head of the department at St. Martha's Hospital, Bangalore. I left Command Hospital about a year back. Uh, my topic follows Professor Arulkumaran's excellent talk on CTGs and problems in labor. So I will be talking on antenatal fetal surveillance. And I have made this presentation from one of my favorite books, Creasy and Resnick's High Risk Pregnancy. How come? Okay. So, assessment of fetal health is an important part of management of any pregnancy, whether it's complicated or not complicated. So, uh, in low risk pregnancies, we would have a much simpler plan of management, while in high risk, it would be much more detailed, multimodal, and we would use it very frequently. And the management of any abnormality is basically delivery, which is the primary intervention. And it's a very delicate balance between fetal morbidity versus morbidity of prematurity. So the decision to deliver keeps changing with time. So we have to have a good knowledge of the physiology, pathophysiology, and the components of various fetal testing strategies. And this will help us in understanding the strengths and limitations of the information available about fetal health. So basically, any fetal monitoring technology is a screening test for fetal hypoxemia and acidosis. Any such test must have measurable test performance characteristics, including sensitivity, specificity, and positive and negative predictive values. Unfortunately, there is no single test which yields the ideal requirements, and hence use of multiple modalities is likely to yield better and reliable results. So how do we assess normal fetal physiology? So we assume that a change in fetal behavior implies that there's a change in fetal status. We assess fetal behavior by asking the mother about her perceptions of fetal movements, we do something called a non-stress test and the fetal biophysical profile. Then, how do we assess the placental etiologies of fetal compromise affecting fetal behavior? This is by doing Doppler studies of the umbilical arterial blood flow and uh, other Doppler studies of the fetal arterial and venous vessels, and of course, the assessment of fetal growth. As gestation advances, the fetal heart rate is increasingly dominated by the parasympathetic system. So with time, there's a gradual reduction in the fetal heart rate. There's an increase in variability, and there's an increasing responsiveness of the fetal heart to acute changes in fetal status. For example, accelerations and decelerations related to awake states, movement, etc. And basically, the ability of the fetus to accelerate its heart rate in response to movement is related to fetal oxygenation and metabolic state. So, a little about fetal behavior. Fetal movements appear in the first trimester, which we can always see on the ultrasound, and breathing can be seen by 21 weeks gestation. And by third trimester, kicking, hand movements, fetal breathing, other movements can be seen and felt. So, there are two fetal behavioral states that have been described. One is quiet sleep, and the other one is active sleep. During quiet sleep, there is REM movement, but otherwise, there is not much of physical movement of the baby, and the heart rate uh, is not very variable. During active sleep, the baby is much more active, moves, and there is a response of the heartbeat to the movements. So basically, if there is presence of normal fetal tone, movements, breathing, then we know that there is most likely no fetal hypoxemia or acidemia. So fetal heart rate monitoring is a valuable component of virtually all multivariable fetal assessment schemes. It relies on the unique coupling of fetal neurologic status to cardiovascular reflex responses. It is easy to do and can be performed in the OPD. It is the most sensitive short-term predictor of worsening hypoxemia and acidosis during labor and is used extensively, as we saw in the previous class. So non-stress test is a combination of fetal movements and fetal acceleration, FHR acceleration. Everybody knows how to do it. It is being done day and night. So I will not go through the details of the non-stress test. If it is reactive, then we are very happy as it has uh, we can say that the fetus is unlikely to die within 1 week. If the NST is not reactive, it does not mean that the baby is not good. We just have to back it up with another system of testing. And the longer we keep the trace on, we are likely to get a reactive NST. So a study showed that 40 minutes monitoring reduces our non-stress NST result to less than 6%. Now we come to the biophysical profile. About 20 years back, when I was doing my post-graduation, biophysical profiles was very commonly performed because none of the ultrasound machine had any Doppler facility. Doppler facility was a accessory in high-end ultrasound machines in that time. So biophysical profile relies on the premise that multiple parameters of well-being are better predictors of outcome than any single parameter. So the 5 parameters in BPP are fetal breathing movements, body or limb movements, fetal tone or posture, non-stress test, and amniotic fluid evaluation. Amniotic fluid Fetal oliguria in an anatomically normal fetus is a consequence of redistribution of fetal blood flow away from the kidneys and reflects uteroplacental insufficiency. So there are two systems of monitoring. One is the AFI and the other is the deepest vertical pocket. Fetal breathing. Again, this is very easily suppressed by hypoxemia, but also it is the most episodic. So it takes a long duration of monitoring of the fetal breathing to pick up whether it is acidosis or not. Fetal movement and fetal tone. These two also require long duration of monitoring, especially for fetal tone. The interpretation, a BPP of 8 by 8 is as good as 10 by 10 or 8 by 10 if AFI is normal, and it tells us that the baby is normal. 8 by 10 with oligo and 6 by 10 non-oligo. So because there is reduction in amniotic fluid volume, it tells us that there is some problem with the uteroplacental flow. So an NST with AFI or amniotic fluid level monitoring is as good as doing the complete BPP with fetal tone and fetal breathing. So now that is more common and it is called the modified biophysical profile. VAS is an addition to improve the NST if it is not reactive. And since the baby is very responsive to vibration, and by third trimester, even the hearing of the baby is pretty developed. So giving a stimulus by vibration and sound jolts the baby, and uh, the reaction of the fetus is seen by the improvement in the NST. So only advantage is that it reduces the duration of the monitoring. CST, again, I don't think anybody does it anymore, and we have never done it in our practice. Now we come to Doppler ultrasound. So Doppler velocimetry allows assessment of placental status. It helps to place other testing results in context. And it also helps us to determine the relative risk of sudden fetal deterioration. Now, a Doppler can be done of different vessels. The commonest is the uterine artery velocity. This is done in the first trimester. The umbilical artery Doppler, the middle cerebral artery, and the ductus venosus. These are the three commonly used. The umbilical artery Doppler is more to show the resistance of the placental system, while the middle cerebral artery is used more for monitoring fetal anemia and centralization of blood flow with brain sparing effect. So umbilical artery, it mirrors the downstream resistance of the placental circulation. In a normal physiological process, the umbilical artery resistance falls progressively through pregnancy, reflecting the increased numbers of tertiary stem villus vessels. Increased resistance in the umbilical arteries represents pruning of the placental arterial tree. As umbilical artery resistance rises, diastolic velocities fall and ultimately become absent, otherwise known as the absent end diastolic velocity. As resistance rises even further, there is an elastic component which is added, and it causes the reversal of the end diastolic velocity, as the insufficient rigid placental circulation recoils after being distended by pulse pressure. Umbilical artery Doppler assessment is beneficial in the management of high-risk pregnancies, especially those complicated by fetal growth restriction and placental insufficiency. Now we come to the middle cerebral artery. Middle cerebral artery is basically monitored for fetal anemia. The peak systolic velocity can be used to evaluate the absolute speed of blood flow and has direct application in fetal anemia. The peak systolic velocity rises as the fetal hematocrit falls and the oxygen carrying capacity of the blood falls. The cardiac output increases and the transaortic velocities increase. Key MC abnormality expressed by the compromised fetus is centralization. Though we know that fetal anemia causes an increase in the systolic velocity of the MCA, how does placental abnormality cause change in the MCA? That is the question, and it could be compensatory because of parenchymal vasodilation by active mechanisms, or involuntary by just increased shunting of blood away from the somatic circulations under the force of hypertension dictated by the accelerating placental vascular resistance. These changes may occur gradually, indicated by subtle alterations in the cerebroplacental ratio, which reflects the calculated ratio of the resistance indices in the MCA and umbilical artery. This ratio changes in response to redistribution of blood flow, which is the first stage of brain sparing. However, MCA diastolic velocity is not independently predictive of fetal outcome. It just provides additional information to add to the clinical picture. Now, evaluation of the venous system in the fetus. The venous Doppler chosen is the ductus venosus. Ductus venosus is a sharply tapered conduit that shunts blood from the proximal umbilical vein directly into the inferior vena cava at its connection to the right atrium. It delivers a highly oxygenated blood at high velocity directly to the foramen ovale, keeping it open and promoting right to left shunting of this nutrient-rich stream. In healthy fetuses, the ductus venosus regulates the distribution of oxygen and placental nutrients by restricting the centralization of flow. The phases of ductus venosus correspond to cardiac events. During atrial systole, reduction in forward flow always occurs, producing the most notable characteristic of this waveform, the A wave. It is similar to the jugular waveforms. The A wave becomes progressively deeper as high afterload develops as a result of adverse placentation. It basically indicates poor cardiac function in the fetus. Venous Doppler allows shorter-term prediction of outcome, including perinatal mortality, acid-base status, birth asphyxia, and requirement of intensive neonatal support. Ductus venosus deterioration frequently precedes and strongly predicts changes in BPP that require delivery. But in the extreme preterm pregnancy with the fetal growth restriction, if the ductus waveform is normal, it gives reassurance that even in the presence of significant arterial abnormalities, the preservation of normal ductus flow and normal biophysical variables strongly correlates with normal fetal status and allows us to extend the pregnancy for some more time. So in the pattern of deterioration, what starts first is the placental abnormality. As the placental abnormality becomes worse over time, the first changes that occur are in the Dopplers. And as the abnormalities progress further, the changes can now be seen in the fetal behavior, which can be picked up by maternal assessment of decreased fetal movements NST, and the BPP. So what are the practical aspects of fetal testing? Basically, who to test, when to test, and how to test. So maternal risk factors and pregnancy-related conditions, which are known at the time of conception and during the antenatal visits, they dictate who will be who will be a candidate for fetal testing. When to start is not well defined, but usually everybody starts around 32 to 34 weeks gestation. And in uh, pregnancies which have got early onset growth restriction, it could be started even earlier, around 28 weeks. And usage of multiple methods give the best assessments, that is by fetal movement assessment, NST, biophysical profile, and the Doppler studies. In summary, all pregnancies need an antenatal fetal surveillance plan. Low risk pregnancies may have simpler plans with more clinical methods. High risk pregnancies will have a more detailed multimodal plan to optimize the time of delivery. A combination of different screening tools working on different principles will give more reliable inputs. Thank you.
Thank you so much, Dr. Sujoy. It was really an insightful session. I would request Dr. Anju, she can share her screen and take forward the webinar.
Thank you so much. After hearing very good lectures from Professor Arulkumaran and Dr. Sujoy, I would like to share a few cases. These are real cases, and with some normal CTG patterns of abnormal CTG pattern, and I would like Professor and Sir to comment and help us how to manage these cases. So talking about the first case, she is a second gravida, para 1 with one live issue with 38 weeks of pregnancy. She had come to us with labor pain. I'll be presenting very short history. Her obstetric history, she had first delivery by cesarean section 2 years back for meconium stained liquor at 39 weeks of gestation. It was a live male baby, 3.2 kg, alive and healthy. Her past history and family history is uneventful, and she's a booked case with a normal antenatal course. On examination, her pallor is present with mild fetal edema. Pulse rate is 100 per minute. Blood pressure is 130 by 84 millimeter of mercury. With systemic examination, no abnormality detected. On a per abdomen examination, it is a single live fetus, term size, cephalic presentation with a fetal heart rate of 134 per minute, which is regular. She's having mild contractions, and clinically the scar tenderness appears absent. On an upper vaginal examination, os is closed, soft and uneffaced, and this is the NST pattern uh, which we could record. Sorry, it does not include the uterine contraction. So I would like Sir and Dr. Sujoy to comment upon. Then I'll give the outcome of this patient.
Yeah, so the trace shows no accelerations, reduced variability, and we have to continue this trace for some time or do other modalities of surveillance, as Dr. Sujoy mentioned, because the trace doesn't really reassure one, the baby is in good health. Were there fetal movements present at this time before she came
No,
in?
sir. She was admitted at 6 a.m. in the morning with spontaneous uterine contractions. And just immediately after 15 to 20 minutes, she was complaining of that she is having a feeling that something is giving away. She told that. Though clinically we could not appreciate any scar tenderness, The fetal heart pattern was like this only. And I took her up for cesarean section, and the
Yeah.
scar had already given way.
Yeah. So it's characteristic there's something going on, but we are unable to say what it is because the Norman Bescher from Australia has described this pattern as impending scar rupture when there is a steady baseline with reduced variability. So the CT is not good, so that is for sure. But the question is, why is it not good? Is it because of the scar? Is it because of infection? And also something is going on. So I think it's reasonable to say if you can't find anything, to presume that there might be a scar problem.
Yeah, so that actually I wanted to say, because clinically it's not always that we appreciate a scar tenderness is there, and
Yeah.
and we might not appreciate decelerations also. So giving importance to what patient is perceiving, and I could say this way, we just because we did cesarean within 20 minutes and scar had already given way, it was just the peritoneum, like visceral peritoneum, which was sticking, and I would have lost this baby.
Yeah, so the Norman Bescher's description is actually usually if there is a scar rupture which has gone through the peritoneum, there's usually bradycardia because there is tearing of the
Yes.
vessels and so on. But if the scar is given way but is held with the peritoneum, visceral peritoneum, then its explanation is stretching of the blood vessels because of the stretching of the scar. So there's compromised blood supply, and as a result, you get reduced variability and nothing else. The oxygenation is reduced. So I think it's just at the verge you were able to rescue the baby.
Yes. Any questions audience would like to ask, sir, and or otherwise I'll proceed to the second case.
Yeah. Good case.
Second case, again just 2 days back, primary gravida, 40 weeks. She had come with a normal labor pain since 3 to 4 hours with no complaints of leaking per vaginum. And she was a booked and supervised case with a normal antenatal period. All the blood investigations were normal. And on examination, her general condition was good and vitals were normal. And on per abdomen examination, it's a 36-week cephalic presentation, singleton pregnancy, fetal heart 136 per minute regular with mild uterine contractions. On per vaginum examination, she was 3 to 4 centimeter dilated with 80% effacement, with presenting part vertex at -3, and membranes were absent, and there was meconium stained liquor. And pelvis was adequate, though she didn't complain of any leaking per vaginum, but membranes were absent and there was meconium stained liquor. And this was the NST pattern, CTG pattern.
So it shows a baseline rate on the tachycardic range also within the normal. The variability is maintained, but there is some problem with the cord because there is some variable deceleration. The contraction is incoordinate pattern. It doesn't mean inefficiency, it's just a description. 2 contractions coming together and then 2 contractions
Yes.
and so on. So the chances are actually with the meconium staining, how thick was the meconium and what was the quantity of meconium?
It was a thick meconium, and we had explained to the attendants, and they wanted a trial of normal vaginal delivery, and we had explained them, and we augmented labor with oxytocin and with continuous monitoring, and we did an assisted vaginal delivery almost 1.5 hours later with a vacuum delivery, and this was an alive healthy baby with no signs of asphyxia. APGAR was 789, and baby was temporarily shifted to nursery for observation, but behaved well and transferred to the mother.
Normally, the taking, when I was a registrar 40 years ago, the consultant will come and say, if there is meconium, get the baby out quickly and start oxytocin. But it's contrary to the good practice because what happens when you use oxytocin is actually, although you might expedite labor, you'll produce more contractions. And the baby is more likely to develop hypoxia. So in other words, we had to assume labor as baby swimming from one end of the pool 100 meters to get to the other end of the pool. So if you allow the baby to go once in 10 minutes, then once in 8 minutes, once in 7 minutes, and in between the baby is on the surface, then it will tolerate and will be reaching the other side. But if you give oxytocin and dump the baby too often, then it can get compromised. So it is good that you are able to deliver her, but in general terms, if there is infection or if there is meconium, it will be a good idea to avoid oxytocin because medical legally, 2/3 of
Okay.
cases are linked to oxytocin. So oxytocin we use very
So it is
frequently,
better that we should have gone for cesarean.
either cesarean or if
So
you want
it
to,
would have been better to,
you can,
yeah,
because she's having contractions, so you can let her progress as she is and see what happens. If there's any additional change, if the decelerations become worse, then you have to intervene.
okay.
The fact that you have managed with oxytocin, she would have got more frequent contractions and the pattern would have got worse. So I think if I was looking out of the case, I would just, if some mother says that I want to try and achieve vaginal delivery, I'll say we'll let it be as it is and see how she is progressing and how the pattern is. Because one of the dangers is actually the meconium aspiration is more
Yes.
related to gasping reflex. And the gasping reflex is more common if the deceleration lasts for more than 2 minutes. So when you use oxytocin, for your bad luck, if there were too many contractions, it would have had a prolonged deceleration. The baby would have been born with meconium aspiration. So you're fortunate that you managed quite well. So these are the main reasons that that is thick meconium with prolonged decelerations a few times. Although you might get the baby with crying, but soon it'll have respiratory distress if it has aspirated.
Yes.
So the principle behind not using oxytocin is not only to avoid hypoxic birth, but also to avoid meconium aspiration.
But so then how will we augment labor if supposedly she doesn't progress well? So is there any timeline that we should stop allowing her for a vaginal or after 2 hours or 3 hours? Is there any guideline for that?
No. So what we do is actually we let her carry on for 4 hours. We examine again to see
Okay.
whether there's any progress. Then we rediscuss
Mhm.
with us. There's no progress. What should she like to have? And if the trace is still the same, no rise, no addiction deceleration, if she wants to wait for another few hours, we'll wait. But if she says, okay, I've tried for a few hours, doesn't seem to be progress, then we will suggest a C-section. Suppose if she says, what about using oxytocin? Then we would express our concern, saying that possibly it might cause a problem if there's a bad luck. If everything goes well, it's fine. Otherwise, you'll run into difficulties. Say, for example, if the baby was born and the baby has meconium aspiration and succumbs to meconium aspiration syndrome, then legally, people will point the finger at us and say, this was not the right thing to do. So I think it's a very tricky case. As you have done, it's better to discuss with the woman and then decide. So the timing is not important, whether she delivers at 3 o'clock, 5 o'clock, 8 o'clock. So if she doesn't want section, she wants to wait, then you can wait. So if you wait for another 4 hours, she's still not progressing, then you can at least convince her. In the meantime, the trace might become worse if it is going to get worse. And similarly with infection, if the mother has chorioamnionitis, and then we don't use oxytocin because it has infection has a synergistic action with hypoxia, more chance of brain damage. And if it is infection and thick meconium and failure to progress, then we do a section rather than giving oxytocin. So just a warning about oxytocin that it is used very frequently, but we have to be careful about how we use it.
Okay, sir. But there is no connection with the duration of time baby is exposed to meconium and incidence of meconium aspiration syndrome. No correlation with the time, sir.
That's right.
Duration.
If the baby has simple decelerations, then it is very unlikely But if the baby develops decelerations, and if a couple of them become prolonged, like the last deceleration I can see is lasting for about 2 minutes. If there are few of those 2-minute deceleration, then the baby can aspirate. And depending on the thickness of the meconium, then it might cause problem. If it is fever as well, then the lung get chemical pneumonitis and infective pneumonitis. So the bad combination is thick meconium, fever, lack of progress, and use of oxytocin. So in general, we try to keep the insult to one rather than adding another one. So of course, people do manage, but just to be on the cautious side, and also to realize the fact that the aspiration is related to the duration of the deceleration rather than due to just simple decelerations.
Okay, sir. So it means that we need to explain to the patient that there are chances of meconium can cause what harm to the baby, not only aspiration and prolonged complication like PPHN if baby is having meconium aspiration, prolonged nursery stay, prolonged ventilatory support, and we cannot predict the neonatal outcome immediately on the basis of meconium. So
That is true.
we let the attendants decide what they want and how should we behave like that.
Yeah. So I think if you have more good staff as to give one-to-one care to pick up decelerations, we have monitoring facilities, you can give her more time. Suppose if I say that you have only auscultation facilities like a fetal heart rate by a dot tone or something, and then you find decelerations like this, then you don't know how often this case is going to decelerate within a given period of time, unlike a continuous monitoring, in which case you might advise for delivery rather than to wait. So there are a lot of implications with thick meconium and how to manage it. So it's always the parity matters, the dilatation matters, and she was 3 centimeters or 4 centimeters. So it's and she's a primary gravid, so she would take time. And patience is important. That's very difficult, because they will push, get the baby delivered. So I think it's a matter of balancing. But you're absolutely right. You have to discuss with the patient and make the decision.
Your comment, Dr. Sujoy?
I agree with what sir has said, and she's not in active labor, and station is -3. So I was thinking how she delivered within 1.5 hours of
She delivered. She delivered.
with
And on there were 2 loops of cord around neck also
Mhm.
when she
So
delivered.
if we could have more of these traces, this is right at the beginning. If maybe half an hour or
Yes,
one
sir.
hour later, what was the trace? If I mean, maybe it improved after this. We
Sir,
don't
it
know.
was
This was
like
the
this. No, no. It did not deteriorate like more than this. There were variable deceleration in between, and she was on continuous monitoring, sir.
Yeah.
variable decelerations is basically more likely due to cord compression, and because there were two
Yes.
loops that must be
Of cord
getting
around neck.
cord. So I guess we are lucky in this case that nothing happened. Baby came out so fast.
So, but it
Oh, minus.
is very difficult because, yeah.
No, ma'am,
But
this
it is
is
very
daily.
difficult. Like sometimes Abhi just when you were taking a lecture, I just went to deliver a baby, and she was primary gravida. She had come 5 centimeters in dilatation, and membranes were there. And she just after 1 hour she delivered, and there was thick meconium. We didn't augment. She was going into spontaneous labor. She had rupture. She just delivered, and there was thick meconium. And because I didn't do an ARM, I didn't pick up any meconium. It was immediately at the second stage only I could pick up meconium.
Yeah.
Nothing can be done. 20% plus will have meconium staining in normal babies. So
Mm.
it's just
Yes.
an MAS is not common. It is
Yeah. So I think
some
that the aspiration is a problem if there is thick inspissated meconium, like a pea soup or a gelatinous type of meconium. But if it is watery meconium where it wets the whole bed sheet, then that's the function of maturity rather than due to hypoxia. When there is little fluid, then that's the function of hypoxia as well, because there's reduced fluid produced, and therefore there's not enough fluid to dilute the meconium and becomes thick. Way back in the before Christ sort of thing, Aristotle has described meconium comes from a word mekos. Mekos means opium juice. So they said those babies with opium juice are born flat. So his observation, why he thought the baby drank opium juice is anybody's question, but that was his description. So thick meconium which is inspissated is a big problem. There was a comment on the comment box saying, why can't we dilute the meconium? Well, the results of meconium with amnio infusion, people have tried, but some have said it is positively good, some have said it is positively bad, some say there's no improvement. So we look at the evidence, it is not very conducive that we can. So current thinking is actually every baby is a premium baby. So rather than trying this and trying that, if you are doubtful, then better to do a section and deliver the baby. But if the mother doesn't want a section, then you have to give her the alternative. And if you have facilities for amnio infusion, of course you can do that if you are practiced and if you do that. We used to do that, but now we are given up because it didn't produce the results as we expected.
Thank you, sir. Let's go to the third case. She's a third gravida with para 1 with 1 abortion, with 36 weeks of gestation, pregnancy-induced hypertension on labetalol, 200 milligram twice daily, and she was admitted with complaints of absent fetal movements. And she's a book supervised case. On her obstetric history, she had first cesarean section at 37 weeks, 4 years back, because of PIH and with IUGR with oligoamnios. Born was 1.8 kg and baby is doing well. And next, she had an MTP 2 years back at 8 weeks of pregnancy because it was an unplanned pregnancy. And this third is the present pregnancy. Past history is not significant. Sorry, this trace has been kept here. I'll just come back again. And she's a book supervised case. She developed PIH at 32 weeks of gestation, and she was started on labetalol, 200 milligram twice daily. Her ultrasound at 34 weeks had shown single live fetus, 32 weeks of gestation, cephalic presentation with decreased liger, AFI is 6, with single cord around neck. Her clinical intervention test, SGOT and SGPT were raised, 146 and 138. Alkaline phosphatase was 164. KFT and coagulation profile was normal. Urine albumin was 2. On examination, 100 per minute, blood 40 by 90 with facial puffiness present, pedal edema present. And on per examination, it is 32 weeks of with cephalic presentation with fetal heart rate of 130 per minute. Per vaginum, os was closed and uneffaced. Now I'm coming to the trace at the time of admission. She was not in labor. This is a trace.
This is at 32 weeks or 34 weeks. Is that right?
36 weeks, sir. She's 36 weeks.
Okay.
Her clinically, she looks IUGR, and this was 36 weeks.
Yeah, so
She
trace-
came with absent fetal movement, sir.
So the absent fetal movements is of some concern because of the previous history of IUGR, current history of preeclampsia. I think she has proteinuria and hypertension. The labetalol is an alpha beta blocker, so it can reduce
Yes, sir. Fetal edema, proteinuria, and
yeah. So as Dr. Sujoy mentioned earlier on, sometimes you have to do multiple testing if you want to prove that there is a difficulty, like a Doppler, etc. But looking at the trace, looking at the history of previous section, I would advocate a cesarean section because the trace is not very satisfactory. It may be due to labetalol, but the background of absent fetal movements worries me more. And we can't achieve very much by induction. There's a risk that you might cause to the skull. So putting things, and of course the mother might say, I don't want to have a cesarean section. Then if we have facilities to do a ultrasound to see like a volume, Doppler, and reassure, then it's okay. But suppose if you do that and there's concern, then, and I think you said like a volume was also reduced, 6 centimeters AFI.
Yes, sir. Yes, sir.
Yeah. So for me, I think it is sufficient grounds to be safe because of reduced LICOR, absent fetal movement, non-reactive trace, and history of hypertension treated with. So to me, it's of a high risk, significant enough to advise her to have a C-section, but it all depends on what she wants and what is the alternative.
We did a cesarean section, and to my surprise, baby was alive and healthy, 1.9 kg, but there was meconium strain liquor per finding.
Right, right.
One thing is your paper is at 3 centimeter per minute. We normally see it at 1 centimeter per minute.
Yes,
The
sir.
trace looks a little different at 3 centimeters.
Okay.
We are not used to seeing
True.
at 3 centimeters.
Okay, sir.
A good observation, Sujoy. I didn't notice
Mm.
that. Yeah.
Okay,
And
sir. So I'll now look into that now. Mm.
basically, what we could have done is we would have done a bedside ultrasound, seen the Liker and all, and then gone for C-section. Finally, she's a post LSCS anyway. So,
Yeah.
Yes, sir.
timing of cesarean section was
So I
good.
did a ultrasound and AFI was 6. Dopplers were normal, sir. Middle cerebral artery and umbilical artery Doppler I did, and CPR ratio was more than 1.
Oh,
Okay. Good. So good management. She managed to have a live baby.
What else we could have done, or there was, if she would have been at 34 weeks, sir, if the same case would have come to us at 34 weeks, what?
Well, I think I would have started on betamethasone or dexamethasone just to be on the safe side. And even if it passes 12 hours, it's of some benefit. We timed it. So there was no urgency because I think one dose would have, I mean, probably we wouldn't like to wait too long and repeat the CTG again while waiting. The difficulty with giving steroids in the preterm period is the steroids itself can cause reduction in the baseline variability. So sometimes it becomes confusing.
Yes, sir.
So I think if it is 34 weeks, then you have to balance whether to give steroids. Generally, by 34 weeks, if the baby also suggests IUGR, then the lungs get mature because of the stress of IUGR. So it's not that 100% important, but I think in balance, I would have done the same thing at 34 weeks, just taken her for a section. Because at
Sir,
34,
how much importance should we give to the absent fetal movement complaint patient gives? Like if we are monitoring her with the Doppler ultrasound, we are continuously, maybe every alternate day, if we have the facility, but persistently, if she says that she doesn't have fetal movement, she can't perceive, and even if we can't see any acceleration on CTG, then there is no point monitoring with the Doppler. And should we go for a cesarean section, giving importance to that?
yeah, so I think in general terms, actually, the first sentence of Sujoy's presentation is the most important one. There's no single test which is 100% foolproof. You can get the baby with a normal Doppler and the baby can perish next day. CTG can done. And if the CTG is non-reactive and the volume is reduced, then the predictive value of CTG is also not there. It can die within the next. So based on huge studies by Manning on biophysical profile, volume takes the precedence compared to even CTG. But if both are abnormal, then there is a problem. So she has reduced volume, abnormal CTG, reduced fetal movements. There are three parameters compared to the Doppler being normal, and that doesn't reassure me so much. I can only say that it might unlikely to die very quickly, but there is a problem. And the sensitivity of the Dopplers tend to go down as the pregnancy progresses. You can't depend on the sensitivity of the Doppler. The placento-cerebral placental ratio, which has been beaten about quite a lot, has now come into severe question, whether it's a valid test and whether it can hold true in terms of sensitivity and specificity. So I would go by the absent fetal movements, reduce variability with a trace, reduce volume, hypertension on drugs. So these are clinical parameters which go by. Now there's 4 years the Royal College has done studies looking at all the severely neurologically handicapped babies and stillbirths or immediate neonatal death within 48 hours. And the study is called Each Baby Counts. Each Baby Counts. That is actually, if you type it in the Google, it'll come up, Each Baby Counts. And CTG is one component which shows something problem. But major thing is actually clinical risk factors being ignored. And third is actually non-communication, personal issues, and so on. But clinical risk factors has been highlighted as an important because many of the cases which are neurological handicap and stillbirth, they said there are absent fetal movements, there are some hypertensive disorders. CTG was neither here nor there. Dopplers are normal, so they decided to wait, and things have gone wrong. So I think it's a key issue to remember. At least one lesson from Sujoy's presentation is not a single method is foolproof. We had to take the whole thing, but the clinical risk factors has to be given more chance. Because every day we get in the newspapers, mothers coming and complaining. I went to the hospital saying the baby did not move. I was hypertensive, I was on drugs, and they said there was reduced LICWA, and still they didn't deliver or done something and things have gone wrong. So I obviously would like to discuss with the mother about the alternatives of your concern and give what you think is the best. But if she says, well, we have to say what will happen if you do follow your recommendation and what is the alternative? That's the question. So I think what you have done is right, and I think we would have all delivered by C-section.
There are lots of in India of what I feel after COVID, I'm seeing a lot of diabetic patients or developing diabetes in pregnancy. It is an increase, and they usually complain, even if the sugars are well controlled, they are complaining of absent fetal movements at around 32 weeks, 31 weeks, or 33 weeks. So giving a betamethasone in diabetes is again an issue. It is to be given with this insulin cover, or we need to control sugars, and whether to deliver, because diabetes causes a delayed pulmonary maturation also. So taking a decision to deliver such mothers early preterm is a double-edged sword, whether we are combating with the prematurity, or if we let the labor pregnancy continue, we may land up with a intrauterine demise. So how do we manage these cases, sir?
Right. So I think the important thing about diabetes is actually if the blood sugar controls are quite good, then they don't get problem with the fetal movements. But if the mother has hyperglycemia, hypoglycemia, then it causes a problem to the baby. And especially you might find a case of diabetes where the CTG shows a baseline which doesn't stay in a straight line, but is undulating up and down. That is due to metabolic disturbance. And you correct the blood sugar, it comes back to normal. So whenever the mother says fetal movements are reduced or absent, the first thing I will go for is blood sugar. I don't know whether I can show you a graph on a phone. If I can get it. Right. Okay. I don't know whether I can see a phone. No, it's no.
Roshni, how can I share that on phone? Should I stop sharing?
No. You can look at my screen. Well,
Okay.
I don't know whether you can see that. Well, essentially, what it is continuous monitoring of the mother. And the graph shows there is a certain point where it has dropped to nearly 3.4 millimoles, which is equivalent to about 60 milligram per deciliter. At that time, she came with feeling unwell, and we did the trace, and it was undulating CTG trace because of the drop. And once you correct the sugar, then it came back to normal. So I think the problem of diabetes is, if it is in the early period, is the glycemic control. And if it is not controlled properly, then they can get a sudden fetal death. Because the mother's blood sugar is too high, the baby secretes too much of insulin. As we know, the babies who die have increased pancreatic mass with increased in the pancreatic cells, there is increased suggestion of production of insulin, and they get severe hypoglycemia. That's why we check the blood sugar soon after birth and feed early and so on and so forth. So diabetes is a big problem, and I think the first thing is to check the blood sugar and to control it. The second issue which you raised is that more mothers are getting diabetic. We also find it, I'm not very sure whether it's due to COVID, it could be, but we are getting more mothers who are elderly and also who are getting twin pregnancies and on higher BMI. So that causes the other issue. And so we get higher cases, and giving dexamethasone or betamethasone if it is necessary, then of course we have to check the blood sugar and give it and expect that it might be of benefit. So what you said is absolutely right. Because of diabetes, the type 2 pneumocytes don't produce enough surfactant, because the function of the beta mimetics or dexamethasone is to release the surfactant from the stored type 2 pneumocytes. So it releases into the alveoli, and then the babies don't get it. So we have to really get whatever surfactant it has produced, released into the alveoli, but at the same time keep control of the blood sugar. So it's a difficult process. So you have to keep the glucose and the insulin ready, and give the steroids, and if necessary, give the insulin to control the blood sugar while you are giving the steroids.
Thank you, sir. Dr. Sujoy, any further inputs from your side, sir?
No, ma'am, I think you did a good job in this case. And diabetes, we are also seeing diabetes very commonly in our OPD. And what I do is I sit with them and spend half an hour just telling them how to change certain things in their diet. Basically, increase something, reduce something. Because most dietitians, they put them on an alien diet. So South Indian is told to eat chapati, and a North Indian is told to eat this. So that causes a lot of problem. So I just sit with them, I see what they eat, and I just tweak that itself. Reduce the idlis, increase the sambar, that kind. But it's very effective.
Mm.
And I start insulin, at least long-acting insulin, if I find that sugars are not well controlled.
Yeah.
Mm.
I think what is also is coming up, I'm sure you all are aware of the the small sensors which they put on the back of the upper arm, and what they call the freestyle produced by Abbott and other companies. And you can have, as I'm showed on the phone, the graph to really show the mother how the blood sugar is functioning, and there are two lines. The sensors are quite expensive, but for a pregnant mother who is taking insulin, it's a good idea to have, if possible, to have the sensors. Because it's difficult to get, I mean, the olden days we used to do a pre-prandial, post-prandial blood sugar, so you had to pick before and after and so on. It's cumbersome. Whereas this one, you put a patch and for 2 weeks, she knows if she eats this, it is going up. If she eats that, it is coming down. She does some exercise, it is better controlled and so on. So I think the future of medicine will be controlled by the data which we get digital based on what we get on the devices, which is like the phone, which will be very handy.
It's available, sir, but it costs around 10,000 rupees,
Yeah.
more than that per month. So either she buys the insulin or she buys the machine.
So it's very difficult task, but I think that's the way the medicine is going to go. I mean, sooner or later, people will be producing it at a cheaper price, and because each patch lasts for 2 weeks, so I mean, rather than pricking about 10, 20 times, then this might be something, and they should be able to control their diet. So they had to be told not to have hypoglycemic episode and not to have hyperglycemic episode. So while they're eating, if things are going up, then they can stop it. If they're going down, then they can take something. So I think the future of medicine has hope that we can manage it better. And
So till now, I'm still doing that 6 times sugars, at least in a week, with patients on insulin fasting, post breakfast, post lunch, and post dinner. But I've seen people monitoring with 1 time post lunch, next week post dinner, next week post breakfast. Is that a good idea?
No,
well,
ma'am.
I think it's better to have a 1 day blood sugar profile. So normally what we do is we
Yes.
get them to the hospital and do one fasting and then ask them to take breakfast and then do another one and then. But if the woman is quite knowledgeable of what she's doing, we give them the blood sugar monitor to take it home and note it in a book and bring it. And the monitor itself has all the recordings, so you can take it and read it.
Thank you, sir. That's all from my side, all the 3 cases.
Thank you for presenting all the wonderful cases, and to Sujoy for the wonderful presentation. So questions, Janitri is going to coordinate the questions.
Thank you so much, Dr. Anju, for bringing up such interesting cases, and Dr. Arun and Dr. Sujoy for your comments. I hope our participants must have got an idea, if they have ever across these cases, how to handle these cases now. We do have some questions, so I will just call out these questions and you can answer. First is the role of continuous electronic fetal heart monitoring in low-risk pregnancy.
In low-risk pregnancies, yeah. So if it is low risk based on clinical history and examination, then there is no necessity to do continuous electronic fetal monitoring. They can do intermittent auscultation. And at the beginning of labor, the first thing to see is to check the symphyseal funnel height and ask for fetal movements from the mother. If the baby is moving, and if you can observe as a doctor or midwife the fetal movement, that's the best answer. But it is easy to do an admission test, not necessarily using a CTG machine, but by listening to the baby and recording the rate, and then palpating the mother's abdomen and perceiving the kick of the baby by yourself and the mother, and say fetal movements felt at that time, to listen to the heart rate, it'll show acceleration. So if you do a proper admission test on auscultation, if it shows a fetal movement and acceleration, that baby is unlikely to run into trouble in the next few hours. And then you can keep that baseline and intermittently monitor the heart rate after contraction to hear for any deceleration. So the quick answer is yes, you can do intermittent auscultation, but a thorough history, clinical examination, followed by an admission test by auscultation to look for fetal movements and accelerations, and a contraction following which to listen for any deceleration. If it is absent, then you can do continuous or intermittent auscultation. In other words, if you do a CTG, there is no hypoxia without deceleration. So after that, you can, at regular intervals, listen soon after contraction. And if there are no decelerations, you can continue with intermittent auscultation.
Thank you, doctor. Second is 3 centimeter per minute or 1 centimeter per minute strip better? Which one is better, they're asking.
Well, I think Sujoy pointed out, it all depends on what measurements you are used to. If you are practicing in Japan or America, they run at 3 centimeters per minute because they think they can see clearly. And as you know, America, everything is big, from hamburgers to cars to everything is a big size. So they like 3 centimeters because they want to see the decelerations big enough, but it confuses the variability. So that's the problem. So if you're used to 1 centimeter, then you must stick to 1 centimeter. So it doesn't matter. And those days we say they waste paper by running at 3 centimeters, but nowadays it's read off the screen. So you don't have to really use paper. So it doesn't matter 1 or 3, but they must stick to the speed with which they are familiar with.
Next we have is the role of fetal medicine expert in today's era.
We'll ask Sujoy and Anju to chip in.
Fetal medicine expert is required for management of high-risk pregnancies and maybe do more advanced ultrasounds, genetic testing, those kind of things.
I don't think, because it is a management by an obstetrician, and an obstetrician should be well versed with doing, I think, in a today's scenario with a Doppler ultrasound and a assessment of the fetus, the liker, because fetal medicine would do a detailed survey of a fetal anatomy, maybe that too at an early gestation, and any intervention which is to be needed. And as a obstetric management, fetal
We don't need
medicine role not.
Right, ma'am.
What I feel.
Yeah, that's correct. So in other words, good care for all, but more care for the needy. So when it is more care is needed, then you refer to the fetal medicine expert. But most women will need good care, which can be provided by an obstetrician who can take a good clinical history examination, do simple ultrasounds and Dopplers and so on.
Fourth question is doing an admission CTG mandatory?
According to the NICE guidelines, it is not mandatory, and the Cochrane database also says there is no particular advantage of doing an admission CTG because it increases the number of cases electronically monitored more and also a little bit more interventions. The first admission CTG study was done by my group from Singapore, which we found quite useful. It was published in 1986 or 87, where the antenatal care was not that optimal in Singapore at that time in the 1980s. So we know symphyseal funnel height measurement, we missed a lot of growth restriction. So we used to do that and we found it useful. And Scandinavians like Norwegians and Swedish still do it and that is mandatory in Sweden because they think it's beneficial. Whereas we in England, NICE guidelines and Cochrane says there's no evidence because there are no randomized controlled trial has proven to be of a beneficial. But if you look at the trials done, there has been problems with the trial. The numbers are not enough. And secondly, the largest study in Dublin done by Lawrence Impey and his group, they ruptured the membranes first before they randomized the cases. And if there's clear LICOR, then they randomized it. But if there's no LICOR or meconium, then they put them on the CTG. And the time of rupturing the membranes, the cervix was less than 2 centimeters. So which is not ideal. Like the women in England won't permit you to do a vaginal examination and rupture the membranes, which is less than 2 centimeters. So the trial has to be interpreted that if you do a rupture of membranes less than 2 centimeters, if there's clear LICOR, then there's no benefit of doing an admission CTG. So there are a lot of problems with the current evidence we have. So in my books, actually, I think it is not mandatory, but if you do it, so much the better. You have a record. And nowadays you have a graphic Doppler, which the standard Doppler has a graph, which you can do an admission test. But if it is not available on auscultation, you ask the mother, listen, and it is 140, then you put the hand. When the baby moves, you listen. It goes to 160, then there's a contraction, you listen soon afterwards. There's no deceleration. That's a good enough admission test as an admission CTG.
The last question we have is how much time we will extend ANC period in IUGR and oligo patient on basis of CTC?
So the question is, if there are IUGR and there is oligohydramnios, and what is the other one?
They're asking how much time we will extend ANC period in IUGR and oligo patient on basis of CTG.
I think Sujoy gave the answer. Sujoy, you might want to repeat that, what you said in your lecture.
So, oligohydramnion indicates that there is a problem with the maternal fetal interface, and it is affecting the fetus by changing the circulatory system in the baby with brain sparing effect. And we would rather see the interval growths. If the growth has stopped, LICOR is reducing, the CTG traces have become worse, then we would try deliver the baby. But if the interval growth is there, LICOR is on the borderline, but it is maintaining, though we would like to pull it on as far as possible. So just on CTG, we will not take a decision. We'll take a decision on so many things, on fetal movement perceptions, the interval growth in the fetus, and the LICOR. So
Yeah,
that's
so
what I think.
in short, if I expand on Sujoy's answer, there have been large studies done called the truffle studies in Europe, which is comparing the ductus venosus flow
Yes, yes.
versus the computerized CTG and so on. So it all depends on the gestation at which the problem is happening, because if it is at 34 weeks and beyond, then there's oligohydramnios, there is IUGR, there's no fetal growth. No fetal growth at any stage needs careful consideration for delivery. But if it is growing, then still like a volume is reduced, you can carry on. But 34 weeks and afterwards, the tendency for intervention has a low threshold. So you just deliver them because the baby is going to be okay. But 28 to 34 weeks, then you depend on number of modalities, like a volume and umbilical artery Doppler and the ductus venous flow. If the umbilical artery Doppler is absent, then you had to switch
And
on
then
to ductus venosus flow, because it can be absent for more than a week and before it becomes reversal. So if there's reversal of end-diastolic flow or problem with the ductus venosus flow, then you had to think of delivery.
Thank you, doctors. That was the last question. So we can end today's session.
Thank you very much.
thank
Thank you, Sujoy, and thank
Thank
you.
you, sir. Thank you,
Thank
ma'am.
you, sir.
Thank you.
Thank
It's
you,
always a
Dr.
pleasure
Sujoy.
interacting with sir.
Oh,
Yes,
His
sir.
concepts are so crystal clear that even I forget what I came to talk about listening to sir's talk.
Those very good cases by Anju and good discussion, Sujoy, about the antenatal surveillance and good questions by the audience. So extremely good. Thank you, Janitri, and
Mhm.
all the
Thank you,
best.
sir.
And a wonderful new
Thank,
year with good health and happiness.
thank you. And we wish you same, sir. Thank you so
Thank you
much.
very much. Thank you.
Thank you.
Thank you, doctors. Thank you for your time today.
Thank you.